Hello， 大家好，翻嚟啦！我哋即將會開始第二節嘅演講嘅主題係二級預防，提升健康意識，達至健康生活。呢一節公開討論嘅嘉賓係香港復康會嘅委員馮家聰先生，而佢亦係香港復康會數碼轉型委員會嘅主席嚟嘅。首先有請香港復康會賽馬會健康起步計劃註冊社工文思懿為我哋分享透過電子模式的健康嚮導服務，推動健康行為改變的經驗分享。
大家好，我係香港復康會賽馬會健康起步計劃嘅社工 Mancy， 今日會同團隊一齊同大家分享一下我哋透過電子模式嘅健康嚮導服務，去推動健康行為改變出現嘅一啲經驗嘅。我哋香港復康會一路都係好積極咁樣去推動健康管理啦，而我哋喺2000年嘅時候就由美國史丹福大學引入咗一套小組模式嘅慢性疾病自我管理課程。喺個社區入面都推行咗好多年都見到有佢嘅成效喺度嘅，能夠係協助嗰啲長期服務長期病患者去做到佢哋嘅疾病自我管理啦，提升佢哋嘅自我效能同埋生活質素。不過我哋都留意到小組模式嘅服務喺個別照顧上面係有佢嘅限制喺度嘅，參加者係有時會需要一對一比較深入嘅個人化跟進，所以我哋就喺2019年嘅時候開始將 health coaching健康嚮導呢個理念同埋服務由外國引入嚟香港嘅復康服務，設計咗一套本地化嘅服務。我哋呢一個健康嚮導服務就率先係喺賽馬會健康起步計劃入面去推行啦。咁我哋服務嘅地區係沙田區，參加者入嚟我哋呢個計劃就會接受一個為期3個月，結合咗個人化同小組模式嘅健康管理服務嘅。咁佢哋參與我哋活動嘅時候上咗一啲小組嘅活動啦，學咗一啲自我管理嘅知識啊、技巧。但係有時可能就缺乏一啲動力啊、信心。咁所以喺呢3個月入面我哋都安排咗有個人化嘅健康嚮導服務跟進嘅。我哋呢一班嘅健康嚮導係一班受咗培訓同實習嘅義工啦。我哋係將過往health coach 好多時係由一啲專業人士，譬如社工啊、醫療人員去擔任嘅。咁我哋亦都將佢推廣咗，係俾一啲社區人士，特別係一啲過往係一啲長期病患者啊、照顧者或者退休嘅醫護人員去擔任啦。咁我哋都一路有一個同行嘅理念，都好想就係用翻佢哋過往自己嘅一啲經歷啊，佢哋嗰個同理心會大啲啦，同埋可以作為一個鼓勵啊、榜樣咁樣去互相支持翻嗰啲參加者。另外就係都可以動用翻一啲嘅社區資本。咁我哋嗰個服務嘅對象就係一班40歲以上有三高、失眠或者痛症嘅人士，希望可以去提升參加者嘅自我效能，去促進佢哋持續嘅健康行為轉變嘅。咁呢班健康嚮導就要喺3個月入面用1對1嘅形式提供5次嘅跟進。咁係做啲咩嘅就係去同佢哋用一啲引導啊、支持嘅方式去訂立一啲個人化嘅健康目標啦，同埋一啲行動計劃，希望佢哋可以實踐得到嘅。截至今年嘅8月我哋已經係培訓咗80位嘅健康嚮導，同埋有超過200位嘅參加者接受過呢一個健康嚮導嘅服務㗎啦。我哋呢一個健康嚮導服務用咗一個主要嘅介入手法，就係動機式訪談法啦。佢係一個具有實證研究支持嘅系統性訪談方法嚟嘅。咁我哋都參考咗外國嘅應用啦，推廣係俾呢一班唔一定係專業人士都可以應用得到。咁我哋相信參加者其實都有佢自己嘅強項啊、潛能啦。咁所以我哋用呢一個方法就係去發掘啦，推動翻佢哋嗰個改變嘅動機，從而促進佢哋作出一啲行為改變，實踐健康生活嘅。過往我哋都有做一啲研究去探討下我哋呢一個健康嚮導服務嘅手法嘅成效啦。喺呢一個健康嚮導先導計劃嘅時候我哋都有去訪談咗14位參加者啦，去了解呢個服務手法對於佢哋改善身心健康嘅成效係點。 咁我哋見到咧，呢個服務1對1形式嘅跟進啦，同埋健康嚮導嗰個嘅角色嘅定位，都係可以整體改善到參加者個身心健康嘅。譬如話咧，佢哋嗰個互動性啊、投入性會高啲啦，會覺得係度身訂做一啲，有個同路人嘅感覺，同埋咧就係嗰個嚮導都好重視參加者嘅個人意願啊、啟發啊，俾一啲嘅支持鼓勵都好大幫助。其次咧就係我哋見到喺呢個計劃下面咧，參加者佢哋嗰個身心健康改善係有所提升啦。佢哋亦都分享咧佢哋個人嘅心態啊，同埋自我覺察都係有所轉變提升嘅。佢哋會比以前自主多咗啦。對自己嘅一個健康嘅反思亦都會大咗，同埋咧亦都係有助佢哋舒緩壓力啊，改善呢個情緒健康。咁喺呢個成效探討入面咧，我哋見到呢個服務嘅模式咧，都係好值得進一步喺唔同嘅長期病患者都可以應用得到嘅。咁除咗係一啲服務使用者俾嘅 feedback 上面啦，我哋喺賽馬會健康起步計劃推行呢個服務嘅時候咧，都收集咗一啲服務嘅數據嘅。咁我哋見到整體而言咧，都有超過80%嘅參加者對於呢個服務嘅評價係非常正面啦。咁佢哋覺得健康嚮導嘅一啲引導啊、講解可以幫助佢哋去訂立一啲可行嘅計劃，同埋實踐到健康目標。更加有80%半嘅參加者咧係覺得健康嚮導嘅一啲支持啊、鼓勵啊、定期跟進能夠提升佢哋個信心，從而達到有效嘅健康管理。咁所以我哋見到無論係服務使用者佢哋嘅一啲 feedback 啊，或者係數據上面咧，都睇到我哋呢個服務都能夠做到構思嗰陣時嘅一個嘅目標啦，就係去提升佢哋嘅自我效能，促進參加者去管理佢哋嘅健康，作出一啲健康行為嘅轉變。咁點解我哋呢個服務咧會突然間有一個電子模式嘅出現咧？其實主要就係2個原因。第一咧就係本身我哋呢個賽馬會健康起步計劃咧都係好常去用到一啲電子科技啦，去希望提升參加者嗰個自我管理嘅能力同埋對健康嘅意識。第二咧就係因為新冠疫情嘅影響啦，令到傳統面對面嗰個嘅服務模式都有啲挑戰啦。咁對電子服務嗰個需求都多咗，所以咧就開始多咗去用一個電子模式推行呢個服務啦。咁一個參加者如果去接受全電子模式嘅健康嚮導服務會係點咧？咁以下咧我哋就會用下其中一個參加者施小姐佢嗰個接受服務嘅歷程作為例子分享啦。施小姐咧佢今年64歲啦，本身咧就有一啲痛症啊，同埋高血壓嘅狀況嘅。佢嘅脂肪比例啊、腰圍都係高過正常水平，同埋咧係佢雖然知道食甜嘢唔健康，不過咧佢就好難抗拒到嘅。當施小姐咧去接受呢個健康嚮導服務嘅時候咧，佢呢個服務咧係全部都係用 Zoom 形式咧作5次嘅跟進，嚮導咧就會同佢每2個星期去會面1次嘅。咁喺第1節嘅時候咧，嚮導就會用到一啲我哋標準化咗嘅工具啦，一啲嘅電子表格，譬如話係自我管理評估啊、制定改善健康目標嘅一啲電子表格，去喺第1節入面咧了解下施女士佢而家嗰個健康嘅狀況啊、需要啦。同佢咧訂立咗3個嘅健康目標，就係舒緩痛症、腰圍回復正常嘅水平同埋體重管理。另外咧就同佢咧去訂立咗一啲具體化可以達至嘅行動計劃，譬如話係施女士咧就希望可以做收腹運動啦、伸展運動啊，或者飲嘢要走甜呢一啲比較具體啲嘅一啲行動計劃嘅。咁喺第2去到第4節嘅時候咧，嚮導就會繼續用一啲電子表格咧，去同佢制定自我管理計劃啦，同埋咧同佢去檢視下、回顧下呢啲行動計劃嗰個進展係點啊，有冇咩困難去作出調整。譬如施女士佢嘅運動目標都可以做到嘅時候咧，佢又再希望提升自己嘅運動量，加咗慢跑入去。同埋咧，當佢發現去喺飲食上面走甜有啲困難嘅時候咧，嚮導又會再同佢傾下點樣可以容易啲做到咁樣。咁喺成個過程入面咧，其實唔係淨係局限喺嗰5次Zoom 嘅會面嘅，其實成個過程咧，健康嚮導都係有同佢喺 WhatsApp 上面做一啲嘅跟進啦。咁包括咧就係會透過 WhatsApp 去發放會面嘅內容同埋記錄啦，俾一啲嘅資訊，譬如係減重嘅資訊啊，分享一啲運動嘅短片啊、飲食嘅短片啊，一啲介紹健康嘅 App 啦，推薦一啲嘅活動啦。咁另外都會作出一啲鼓勵同埋提點嘅。 咁去到最後一節嘅時候咧，健康嚮導就會再用一啲電子表格，就係一個總結記錄，同施小姐咧去做一個成果嘅總結。咁施小姐喺參加完呢個3個月嘅計劃之後咧，佢個痛症係有所改善啦，肌力咧有所提升，腰圍同埋脂肪比例咧都回落翻一個正常嘅水平，同埋平日嗰個甜食嘅攝取咧，佢都係非常之自控㗎啦。咁當呢個服務嘅模式唔同咗咧，轉咗用全電子科技去做咧，我哋都想了解一下呢個健康嚮導服務推行嘅成效會係點。咁所以咧，我哋喺今年7至8月嘅時候咧，就透過訪談啦，都訪問咗8位去接受過全電子模式健康嚮導服務嘅參加者，都想咧了解下佢哋嗰個建議啊，同埋一啲經驗嘅。咁我哋根據佢哋呢個嘅經驗同意見啦，咁整合咗咧係3個範疇上面咧都包括社交啦、科技同埋安排上咧，其實都有一啲嘅好處啊同埋壞處。喺社交方面咧，參加者都會覺得個會面感覺上咧係比較輕鬆同埋自在一啲嘅，因為咧留喺屋企會覺得舒服啲啦。咁不過咧都有一啲嘅困難喺度嘅，就係參加者會覺得咧比起面對面咧會覺得難咗去建立關係啦，因為始終係隔住個屏幕去見，唔係真人咧，感覺會有少少嘅距離感。同埋咧就會因為可能參加者或者個健康嚮導唔係好熟悉 Zoom 咧，個感覺可能會冇咁好，咁咧佢哋覺得個親切感咧都係爭少少嘅。其次喺科技上面啦，都有一啲嘅科技困難嘅，有一啲參加者提到，因為佢哋唔係好熟悉 Zoom 或者一啲網上嘅軟件啦，有時可能唔識用啊，冇聲啊，揩錯咗掣又好驚彈錯咗個畫面翻唔到去啊咁。咁同埋頭先提到健康嚮導喺個過程入面都會用到一啲嘅電子表格啦，咁所以喺當嗰個嚮導去分享畫面嘅時候，有時啲字體比較細啊，或者參加者用手機呢啲屏幕比較細嘅一啲器材去睇嘅時候咧，就有機會睇得唔清楚。最後咧喺安排上面咧，就係整體其實參加者嗰個感覺咧都係好正面嘅，佢覺得係好方便啦，可以慳翻啲搭車嘅時間啊，比較容易夾時間會面。咁同埋特別因為疫情比較嚴重嘅時候咧，佢哋唔需要出街坐車同人逼啊，佢哋都會覺得係比較安心一啲嘅。咁我哋綜合咗參加者呢一啲嘅經驗同埋意見啦，咁所以咧都就住呢一個電子模式去推行健康嚮導服務咧，有翻喺呢3方面都有一啲嘅服務嘅啟示同埋建議嘅。咁喺社交方面咧，我哋都會建議咧係需要了解參加者個需要，按照佢哋個需要去配對翻健康嚮導服務啦。咁譬如係性格方面啦，如果個參加者佢唔係好熟悉一啲電子工具嘅，咁我哋都會盡量建議咧就係配對一啲比較有耐性啲嘅嚮導去協助呢個參加者啦。其次就係背景上面啦，盡量咧安排翻一啲年齡相近啦、性別相同啦，或者經歷過相類似嘅病歷咧，等佢哋嗰個明白啊理解可以多一啲，都可以協助令到個關係建立會好啲，親切感亦都大啲嘅。咁其次咧就係參加者對於線上會面嗰個嘅接納程度啦、熟悉程度都係好重要。咁如果個參加者其實都好反感，唔係好中意成日隔住個 mon 啊，或者唔係好熟悉，冇乜信心嘅，咁我哋都會去因應呢個狀況去睇下點樣配對健康嚮導。其次咧就係我哋都會建議喺嗰個健康嚮導嘅溝通技巧上面需要多啲嘅提升啦，咁去提升翻佢哋對於動機式訪談法啊，或者一啲關係建立上面嘅技巧掌握啊、熟悉程度，咁我哋會多啲喺培訓上啦、一啲實習督導上面啦，同埋義工月會上面咧去作出一啲嘅支援嘅。咁另外喺安排方面咧，我哋都會建議喺個時間分配上咧都會有一啲嘅注意啦，特別係因為佢都影響咗個關係嘅建立。咁如果呢個嘅跟進咧係會用全線上模式去跟進咧，我哋都會建議咧係俾面見跟進咧需要預留多啲時間同埋空間去做好嗰個關係建立，做好嗰個信任，先至再落去做平時嗰個跟進健康計劃嘅。咁如果嗰個參加者佢唔係好熟悉啊，唔係好掌握電子嘅科技咧，我哋建議就可以用一個混合嘅模式，即係開頭可能用面見方式建立好個關係啦，有個信任嘅基礎啦，咁咧之後先至再用一個線上模式去做跟進嘅。 最後喺科技方面啦，咁咧就係我哋留意到健康嚮導嗰個數碼嘅素養咧都係好重要啦。咁我哋就會建議咧都去加強翻健康嚮導用電子科技嗰個支援啦。除咗唔係淨係一個介入技巧，而係喺呢方面咧都可以去提升翻佢哋個能力啦。譬如佢哋點樣去開一個 account 啊，點樣去分享畫面啊。如果喺面見嘅時候，參加者有一啲困難用唔到，佢哋即時可以點樣去支援啊？咁呢方面我哋都會建議可以做多啲嘅。其次咧就係參加者對於電子模式嗰個嘅接受程度啦。咁頭先提到，例如如果參加者佢好抗拒嘅，咁我哋就未必用嗰個嘅線上模式去做啦。咁如果參加者佢都唔會好大障礙嘅，其實佢都 OK 嘅。咁又其實就可以用一個混合嘅模式或者面對面嘅模式，咁因應呢個狀況咧，去睇下配合用邊一個模式嘅服務啦。咁如果真係全線上或者會用到線上嘅，咁我哋都會建議咧都要加強，唔淨止係嗰個 health coach，而係參加者嗰個嘅電子科技上咧都要支援一下。咁我哋如果有需要咧，同事或者健康嚮導可以點樣去提升翻嗰個支援啦，提供協助咁樣。咁最後咧就係喺嗰個資訊分享方面啦。咁我哋頭先提到咧就係嚮導咧都會用到一啲標準化咗嘅表格嘅。咁咧，所以如果我哋都會建議咧，就係將呢啲表格咧去標準化啦，同埋將啲表格簡化、字體放大。咁例如係用到 PowerPoint 啊或者 WhatsApp 去展示咧，等個參加者可以容易啲睇啊理解啦。其次咧就係我哋香港復康會都有一個一站式嘅健康資訊平台 e2care 康程式啦。咁我哋都可以即係去協助參加者咧用呢一個平台咧，去喺佢哋分享資訊嘅時候可以視像化，而唔係淨係單純用文字去分享，都等佢哋容易啲去接觸到呢一啲嘅資訊。咁所以最後咧，我哋睇翻其實成個健康嚮導服務啊，同埋我哋運用呢一個動機式訪談法咧，都係一啲好特別去新嘅嘗試啦，就係推廣由一啲非專業人士俾社區人士去應用啦。咁我哋見到其實健康嚮導服務都有效，可以提升佢哋嘅自我效能啊，推動佢哋作出一啲健康行為嘅轉變。咁而我哋見到而家社會嘅環境一路轉變啦，特別可能疫情下我哋都會多咗用一啲嘅電子服務。咁所以未來如果我哋越多會用呢種電子模式去提供健康嚮導服務咧，喺運用呢啲電子科技推行嘅時候咧，就可以配合翻一啲嘅支援啊，同埋優化，希望可以令到參加者嘅經驗同埋成效可以更加好。咁我今日嘅分享就到呢度啦，多謝你大家。
唔該晒 Mancy 姑娘嘅分享。接住落嚟，有請 University of Minnesota School of Nursing Assistant Professor Dr. Robbin Austin 社區主導倡議，利用用戶健康數據檢視全人健康。
Hi, my name is Robbin Austin, and I'm an assistant professor at the University of Minnesota School of Nursing. Welcome to my presentation titled Leveraging Consumer-Generated Health Data to Examine Whole Person Health, a Community-Led Initiative. I have no conflicts of interest to report. Here are a few acknowledgements I'd like to say at the beginning of this presentation, specifically my colleagues at the University of Minnesota, Dr. Priya Rajamani, Dr. Karen Munson, and Dr. Mickey Eder, and also our community partner, Mr. Clarence Jones. Objectives for this presentation include describe the need for whole person health approaches and including strengths, discuss the challenges and barriers of whole person health data, and to examine community-led initiatives using consumer-generated whole person health data. We're going to start with a few definitions that have been guiding our work. Whole person health, for example, takes into account a person's environment, physical, psychosocial aspects, as well as health-related behaviors. Using these areas of health really help us to improve empowering individuals, families, and communities to improve their health and well-being overall, acknowledging there are many interconnected components of health related to our biological, behavioral, social, and also environmental. Resilience in our work and strengths we define as assets, skills, capabilities, and abilities of individuals, families, and communities to maintain and improve their well-being in the face of long-term and short and long-term stressors. The need for whole person health really has come from the fact that we understand that care in general is complex and at times often fragmented. Gaps in care, therefore, are inevitable. Human wellness really depends on us using a multidimensional approach, also including multi-systematic approach, and a whole person health, coordinated, patient-centered care, including social determinants of health. We understand that the ability to reframe care and services related to whole person health that include strengths can really give us the ability to shift care and move from disease-focused and deficit care to whole person strengths-based care. The ability to look at a strengths approach we designed a mobile health application called My Strengths, My Health. This work began in 2017 to the ability for consumers or patients to identify and self-report strengths, health challenges, and needs. This work is based on the Omaha system, which is a multidisciplinary health terminology. We have developed the simplified Omaha system terms, and I'll explain the Omaha system a little bit more in detail in just a few slides. But we developed a simplified version of this multidisciplinary standardized terminology to be consumer-facing, validated at the 5th grade reading level, and also community validated as well. This application is available on a web-based, so it is accessible on a phone, a tablet, and also a computer. This app, we now have multiple versions in world languages such as Spanish, Dutch, Turkish, Mandarin, Somali, and also Korean languages. We have several others in progress right now as well. The other idea behind using the Omaha system as a standardized framework really allowed us to have a structured, standardized terminology, which is also the ability for that to be encoded within another terminology called SNOMED CT. This allowed it to be multidisciplinary and also including it to be interoperable, meaning it can be used on several platforms. Taking a look at the Omaha system itself is that this is a classification scheme, and we focused on the problem classification scheme. We have the intervention scheme and also the problems rating outcome scale. So for the classification scheme, you can see that we have 42 health concepts that are centered around 4 domains of health. We have the environmental domain, psychosocial domain, physiological domain, and also the health-related behaviors. These 4 domains give us the ability to capture and look at all of health and healthcare that is encompassing, holistic, and also centered on whole person health. The intervention scheme that we've identified is in the application as what we call considered health needs, and we'll explain that more in detail when we have a few screenshots in just a moment. In the problems rating scales, we allow individuals within the application to provide a rating for each of the 42 health concepts. Here's what these concepts look like in My Strengths, My Health. You can see again, we have the 4 domains. In our application, we then simplified these terms from the environmental, it's called My Living. My Mind and Networks is this psychosocial domain. The physiological domain is called My Body, and health-related behaviors is called My Self-Care. And we'll take a closer look at the healthcare concept. So for example, this is screenshots of what it might look like on a phone. So for example, we ask individuals to provide a rating regarding their healthcare from very good all the way to very bad. And when we analyze the data later, we look at good and very good to be a strength. In the middle, we have what we call our challenges, which these are the signs and symptoms of each health concept. So it would be unique for each individual concept. And on the far right side, we have needs, which are related to the interventions of the Omaha system. And here, the consumer-facing version, we have check-ins, hands-on care, asking individuals if they need more information and guidance, or care coordination. In both the challenges and the needs, individuals can select any, all, or none if none of them apply to them for that specific concept. At the end of completing the application, the individuals have what's called a My Strengths, My Health individual report. And you can see here, this provides what the individuals has provided for within the app. So it can say that their strengths, They are able to identify their challenges and also their needs. So the individual within the app are able to read this report themselves and or print it out as a PDF later on and bring it to possibly a healthcare provider. Again, this is from the consumer or the patient's perspective, it's not clinically driven. This individual may be completing this at their home and or in some of our work that we've been using it out in the community. This slide shows a replica of looking at what we consider the social determinants of health and how this may then replicate and show up within My Strengths, My Health, our application. So you can see that about 80% of healthcare is determined outside of maybe a clinical setting. So we're trying to have a better understanding of how do we bring these data elements into possibly a clinical setting, or the individual can identify these themselves. So for example, we ask about income, we ask about safety at the home and work, we ask about mental health, we also ask about their physical environment, and also health-related behaviors such as tobacco, substance use, exercise, and things like that. So we can really understand that bigger, broader picture of what might be happening with that individual between healthcare visits, but also from their own perspective as well. So our methods for this, I'm going to be sharing two community-driven initiatives that we had where the community really led these initiatives and using My Strengths, My Health to understand what was happening out in that community, specifically during the time period of COVID-19. Our first project was funded by the city of Minneapolis in the state of Minnesota and our community partner, Human Partnership. This was really a academic community partnership, really to understand what was happening during the fall of 2020, COVID-19, and also opioid epidemic that was happening within our city as well. So from this work, we had instead all 42 healthcare concepts. The community specifically chose 13 of the 42 across all 4 domains of health to really understand what was happening from a whole person perspective, specifically targeting these areas that they identified as high need areas within their community. So for example, we had 283 responses from exactly the Minneapolis zip codes that we see here. And we also had 264 from others not identified as Minneapolis or Minnesota zip codes. And I'll share those responses here in just a moment. So for example, for this specific study in the fall of 2020, we had 577 participants. A majority were between the ages of 25 and 44, were male, Black, African American, were Hispanic, Latinx, and married, and they completed this survey themselves. Here we're able to understand what that looks like across all of the 13 concepts. So for example, the strengths are blue, which this parallel line graph is showing that it's sorted by the increasing to decreasing strengths. So for example, individuals had a lot of strengths regarding their home, their spirituality and faith. They felt strong in their relationships, and then they reported no abuse as well. On the far side of the right-hand side of the screen, you can see that there are very little strengths regarding their approach to pain and also sleeping. And we'll identify this later as a high need area for the community to really identify having some more health programming around strengths of sleeping as well. And the orange line here represents challenges, and the gray line represents health needs. And so you can see that we have that the orange line is that there are a considerable number of challenges. However, individuals are still reporting that they do have strengths. And the needs, which is the gray line, it really kind of parallels or mimics what is happening with the challenges. This next slide, we're going to be looking at a different project, same time frame, but 1 year later. So if you think of what was happening around 2020 of COVID-19 versus 1 year later, we had much more strong interest regarding from other communities wanting to be involved in this work and wanting to really understand what was happening from a whole person perspective out in the communities. So we really took we had more community partners involved. And in this specific project, we used all 42 healthcare concepts instead of just the 13. So in this specific project, a little bit different demographic than the first, we had 393 participants, same age range typically, which is 25 to 44. But in this study or this project, we had more of that were female, Caucasian, married, and then non-Hispanic and non-Latinx. So you can see the differences looking at the parallel line graphs. Again, we have all 42 healthcare concepts across the bottom, and you can see the blue line. This is again sorted by most frequency of strengths. That we do have the population itself is reporting quite a considerable number of strengths. Challenges and needs to tend to be slightly higher in this specific demographic or this specific project. And we also identified that exercise was really a big topic for the community to talk about, because it was still in our area. We had a lot of our healthcare facilities and gyms where people may go work out were not open yet because of COVID. And so things were still not completely open as they are potentially now. So individuals were really wanting to know and understand what was happening in their communities regarding exercise. But you can see also on the far right-hand side of the screen that emotions and mental health were also very low in strengths for this specific population as well. So there are limitations of this work, is that certainly by these two projects and having it community-based, it's not representative of all of the city, all of Minneapolis and St. Paul area. But certainly that this work really provided us to have some definition of dialogue around what was happening and gave us some data to provide back to the community to have some meaningful conversations. Certainly, we also had some data quality initiatives. In one of our projects, we ended up moving to a paper format, especially in that fall of 2020, because we had 13 of the 42 healthcare concepts. We ended up providing a paper copy for individuals to identify some of these areas, because maybe a phone, a tablet were not available at that time. And so certainly we were then entering that data later. So there were some restrictions on data quality potentially. We also continue to refine our simplified Omaha system terms. This work is never done, that we're constantly trying to find new ways to identify and say things in a more simplistic fashion for individuals. So that's kind of ongoing work as well. And also that funding sources for community work is sometimes limited. So we are very thankful for our funding and our community partners that we've had, but this is certainly limiting the number of people we can involve in the project because of our funding needs as well. So looking at the broader scheme of this work, we're looking at trying to bring in whole person health into the clinical setting, but also understanding what's happening out in the communities, is that this work really reveals that people do have a lot of strengths despite maybe a high number of challenges and needs. And this is consistent with some of our previous work. However, that really being able to understand how to discuss strengths and how to talk about strengths from a perspective of being able to maybe offset some of those health challenges and needs is ongoing work. Self-reported trends in the community allowed us to have some very actionable data. So for example, the community identifying sleep needs, but also exercise needs, really provided some community health initiatives to move forward for the community regarding these specific health topics, and do some very narrow focused programming and educational work for the community as well. This work really allowed us to have a strong community academic partnership. We've been working with our community partner for a number of years, but being that we now are moving into the phase of COVID, our partnership and really our relationships really allowed us to continue this work throughout the pandemic, but also to continue to have our meaningful conversations and dialogue regarding the data that we are giving back to the community, and having some meaningful conversations that were really led by the community, but us providing the data and just being able to sit back and have that community-driven initiative take the lead. Also, in conclusion, that My Strengths, My Health application really allowed community members to self-report their strengths, challenges, and needs. And so how do we then take this work moving forward from the community into a clinical setting? And that is some of our next steps that we're looking at. And how do we bring this work into primary care? So for example, do patients complete this work at home and bring it in with them for their office visits? Do they have it as part of their initial health assessment, maybe completing this application? But that's certainly ongoing work that we are looking at as well. And that we included informatics students in this work from the very beginning as well. And this provided very meaningful, the ability for our students to understand what it's like to collect data out in the community, and all the processes of analyzing that data, giving that data back to the community, and then in turn helping to interpret and provide some meaningful conversation was really quite informative for our students as well. The standardized language really, again, provided that structure that we need for the data when we are on the back end doing some data analysis. And again, really driving it from that whole person health perspective, that we had the ability to look at it from where someone might live, their health-related behaviors. And again, it's that structured data that allows that meaningful analysis to really represent that whole person health, and also the resilience perspective. And our last little bullet point that we like to mention as well, that the whole person health perspective will really be hidden until we ask the individuals to reveal it. So meaning allowing them the ability in this space to provide that meaningful data within an application that is consumer facing language does provide some meaningful work and certainly a connection with the community going forward. I thank you for your time and your attention, allowing me to present at this conference. So I'd welcome any comments or questions or feedback as well. And I do have a QR code here on the screen for you to take a further look if you're interested in learning more about My Strengths, My Health. Again, my email address is here on the slide as well. So thank you again for your attention, and I appreciate it. Thank you. And here are references as well.
Thank you, Dr. Robin Rose Austin. 最後有請香港中文大學賽馬會老年學研究所護士長王鳳兒女士主講健康寶應用程式。
各位好，我係嚟自香港中文大學賽馬會老年學研究所嘅 Maggie。咁今日啦個主題其實係 Secondary Prevention from Health Awareness to Health Living。咁我都好高興啦，今日可以代表我哋嘅團隊賽馬會流金眾護老友醫道所研發嘅健康寶 eHealth Screen， 咁我今日作為一個分享嘅。咁首先同大家分享一下咧研發健康寶嘅呢個理念啦。好多時長者佢可能開始喺日常生活上面覺得有啲唔妥啦、唔舒服，例如行路有啲腳軟啊、成日好攰啊、冇乜力啊咁樣。咁佢心諗究竟咩事咧？咁啊好正常啦，會去睇醫生。咁你知道等即係睇醫生輪候嘅時間又唔短啦，咁到終於啦可以等到見醫生嗰陣時咧，咁醫生就同佢講啊，其實你唔係有病喎，只係退化。咁喺短短幾分鐘嘅應診時間入面咧，又未必可以俾到好多意見。咁長者可以點算咧？咁所以坊間咧其實都有啲 app 咧，咁大多數都會係比較 focus 喺疾病管理嗰方面嘅，例如啲中風啊或者認知障礙症嘅 app， 咁但係咧就比較缺乏一啲係有一個全面老人評估嘅 app， 咁所以我哋健康寶咧其實即係就係希望可以幫個長者可以令到佢好獨立啦，自己去做到一個全面嘅健康篩檢，咁然之後得到一啲嘅建議啊、結果啊，然之後再睇翻一啲相關嘅健康資訊，獲取翻相關嘅社區資源。咁到有需要嘅時候啦，先至真係進一步要去尋找醫護人員，即係揾翻佢哋嘅專業意見嘅。咁健康寶咧，其實係一個免費嘅自我健康篩檢應用程式啦，係為長者而設嘅平台，令到佢哋咧可以好獨立咁樣完成呢啲測試嘅。咁長者同埋照顧者咧都可以隨時隨地好方便咁樣去做到呢啲測試啦。咁我哋提供咗咧11個長者嘅健康課題嘅健康篩檢，咁當中嘅測試咧都係國際常用嘅老人評估嚟嘅，例如有啲係衰老啊、肌少症風險啊、營養啊、記憶力啊等等嘅測試。咁喺研發嘅初期咧，就透過長者中心，我哋邀請咗20幾位嘅長者去試用，去俾意見嘅。過程入面咧，我哋個 programmer 都在場啦，可以即時親身去聆聽用家嘅意見，直接去做一個改良。當中就包括咗有呢啲 icon 啦，無論係圖案嘅大小，令佢哋可以一睇咧就清楚係做咩測試。咁11個測試入面咧，其實呢一啲譬如衰老啊、肌少症啊呢啲公仔咧，全部都係啲長者佢哋去揀嘅。仲有我哋就應用咗 chatbot 嘅 conversation 啦，咁仿照佢哋日常咧所用嘅通訊應用程式，去點選翻適合嘅答案。咁我哋唔需要佢自己打答案嘅，總之自己揀咗合適嘅就可以啦。咁然之後就撳發送啦。咁發送呢個箭嘴咧，其實都係參考翻佢哋嘅意見，因為佢哋用慣咗 WhatsApp 啊，咁所以好容易就理解到呢個箭嘴咧就係發送嘅意思。 仲有我哋除咗用文字之外，亦都加入咗一啲圖解同埋語音嘅指示，令佢哋更加容易咧去理解測試嗰個問題啦。咁一陣我哋都會有個示範嘅短片，去令到大家更加清楚健康寶嗰個測試流程嘅。好多長者亦都反映啦，希望可以喺更加大嘅屏幕睇到我哋嘅一啲健康嘅教育資源，即係嚟自我哋護老友醫道嘅影片。所以我哋就新加咗呢一個教學嘅功能啦，逐步去教長者點樣投放翻個畫面去個電視嗰度嘅。完成咗測試之後咧，健康寶就會顯示咗測試結果同埋個建議、教育資訊啦，仲有社區資源。咁亦都會有一份報告嘅，可以同屋企人啦同埋專業人員去分享。咁以下就係我哋嗰個示範影片。
觀看測試示範，撳一下健康寶應用程式嘅標示，以進入應用程式。可以首先選擇想做嘅測試，然後跟住健康寶嘅指示作出準備。當你準備完成嘅時候，就可以撳開始測試。點樣同健康寶進行對答？你可以點選最適合自己嘅答案，然後撳發送。測試會提供語音導航，仲會有動畫做指示。
而家請你坐喺凳嘅中間，雙手拎住電話放喺胸前並維持，
方便大家做測試。喺完成測試之後，健康寶會列出測試結果同埋健康貼士。你亦都可以撳返回主目錄去做其他測試。點樣取得自己嘅測試報告？撳測試結果，可以睇返過往自己測試嘅結果。最多可以重溫最近3次嘅測試結果。你亦都可以選擇下載、儲存同列印總報告，以保留記錄。第時可以同屋企人以及專業人員分享。最後，你仲可以點選收看更多影片，觀看我哋更多劉金仲護老友醫道嘅頻道同影片㗎。
好啦，咁睇完個影片之後咧，我諗相信大家對我哋健康寶都有更加深入嘅了解啦。咁但係咧，亦都可能大家有個疑問啦，就係究竟啲長者係識唔識得用咧，或者佢哋係咪真係會用呢啲 app 咧？咁正正就係我哋都好關注呢個情況啊。咁所以咧，我哋好重視 implementation 呢一個 stage 嘅。咁因為我哋相信，無論我哋去研發咗啲乜嘢科技嘅產品，其實最重要咧都係落到地，真係俾長者去應用得到先係最重要嘅。咁所以我哋喺一個 implementation stage 嘅時候咧，就去train up 咗一班嘅護老系啦，同埋老年學嘅大學生，咁咧就同我哋一齊親身以實體 face to face 嘅形式咧，去到多個嘅長者中心啦，同埋地區康健中心，咁葵青啊、深水埗啊、DHC 嗰啲，咁去做一個 workshop 嘅，咁就可以即係親身啦去教長者同埋照顧者去使用呢一個健康寶應用程式。咁同埋 empower 到佢哋去真係完成到11個測試嘅，咁當中超過400個長者啦，同埋照顧者參加，無論係長者啊、照顧者或者 NGO 嘅同工都覺得好有用啦。咁一陣我哋都會分享一下我哋 focus group 嘅一啲 feedback 嘅。健康寶其實喺舊年嘅8月咧已經係上架㗎啦，已經面世咗1年。咁直到去8月21號，目前為止我哋都有大約即係超過咗7100次嘅下載啦。我哋亦都喺 iOS 嘅平台，不論係 iPad 啦定係 iPhone 嘅 free app download 咧，都得到過一啲名次嘅。舊年我哋曾經就做過一個 quantitative 嘅survey，收集咗200幾個曾經參加過 呢個 workshop 嘅長者同埋照顧者嘅一啲意見，超過90%咧係會繼續使用健康寶同埋推介健康寶俾屋企人啦同埋朋友使用嘅，可見接受程度都係非常之理想。咁我哋亦都進行咗9場嘅 focus group， 總共邀請咗45位嘅長者啦同埋照顧者去參加。當中就有啲長者分享啦，其實健康寶咧令佢哋可以進行到自己嘅即係好獨立去完成一啲自我篩檢啦，增加健康嘅知識。咁同埋成個過程咧都係簡單易用嘅，字體亦都夠大啦。咁亦都係讚賞我哋嗰個記憶力測試做得好嘅。至於社區資源方面都覺得非常之有用，令佢哋知道咧有需要嘅時候可以去邊度揾到幫手。咁佢哋亦都好樂意推介俾屋企人用。至於照顧者啦，其實佢哋就會認為指示同埋個界面都好好啦，尤其係可以有語音嘅指示。當中都有照顧者分享咧，因為佢都需要照顧一個坐輪椅嘅媽媽，咁其實健康寶可以幫到佢咧去更加掌握到佢媽媽嗰個身體狀況啦，亦都可以省卻咗要推佢出去診所啊，做一啲檢查嘅時間啊嘅 effort 咁樣，咁所以覺得係非常之幫到佢。健康寶亦都可以咧令到照顧者學到更多嘅護老知識同埋技巧，對照顧者係非常之得益。咁至於一啲 NGO 嘅合作夥伴咧，就覺得健康寶可以令到長者隨時隨地去做到健康篩檢係非常之方便啦，界面亦都係簡單易用嘅，長者亦都好容易明白。學生大使喺推廣健康寶嘅時候，亦都可以 empower 到長者去做一個自我嘅照顧啦，過程亦都係促進咗呢個社會共融嘅。咁總結一下啦，其實健康寶帶嚟咗啲咩 benefit 同埋 impact 咧？咁我哋覺得可以 empower 到長者同埋照顧者去好獨立，隨時隨地去進行到健康篩檢啦，亦都減少咗好多需要外出輪候啊，或者要周圍去揾做健康篩檢嗰個資訊嘅時間，減省成本，亦都有助佢哋咧監測長者嘅健康狀況。咁適時咧就可以尋求專業人員嘅建議，亦都令照顧者更加掌握到長者嗰個身體狀況啦，同埋透過相關嘅教育資訊啦，提升到長者同埋照顧者佢哋嘅健康素養，咁令到照顧者咧喺照顧長者嘅時候就更加得心應手啦，從而可以減少到一啲照顧嘅壓力嘅。咁同埋啦，我哋都發現喺用健康寶嘅時候咧，屋企嘅一啲年輕嘅照顧者啦，或者係我哋嘅大學生嘅大使，其實佢透過用健康寶同長者去進行呢啲測試嘅時候咧，亦都增加咗呢兩代嘅溝通。咁所以我哋覺得咧係可以更加培養到年輕人對長者係對健康老齡化嘅一啲意識啦，成功推動到一啲代際嘅團結，建立長者友善共融嘅社會。咁最後啦，就可以達至到健康老齡化啦，同埋亦都提升到長者嘅生活質素嘅。最後同各位分享咧，就係非常之榮幸啦！我哋健康寶喺今年嘅5月就獲得由新加坡 Aging Asia 所頒發嘅獎項 Innovation of the Year Technology， 同埋我哋嘅網上護老課程都獲得 Innovation of the Year Caregiver Model 嘅獎項嘅。咁呢度咧就係容許我都介紹少少啦，因為頭先即係有講過健康寶嘅一啲健康教育資訊，其實咧就係喺我哋嗰個護老課程入面咧抽取出嚟嘅一啲資料嚟嘅資訊嚟嘅。咁我哋就有一免費嘅網上護老課程啦，分別有專業人員嘅課程同埋公眾人士嘅課程。咁專業人員嘅課程咧完成咗之後，亦都有個出席證書啦，同埋 CNE cert 嘅。咁至於公眾人士嘅課程，咁我哋就有個 YouTube channel 啦。咁主要其實我哋就圍繞住12個嘅護老課題，當中就係包括頭先我哋所提及嘅一啲測試啦，例如有衰老啊、肌少症啊、飲食啊或者痛症啊呢啲等等嘅課題嘅。咁呢個就係我哋護老有醫道嘅團隊啦，亦都係我哋研發 eHealth Screen 嘅團隊。 咁最後啦，就真係想邀請大家可以 scan 呢一個 QR code， 咁去嘗試 download 我哋健康寶呢一個應用程式，咁佢可以幫長者或者可以介紹長者好獨立咁樣去自己完成呢一個健康細檢嘅。咁多謝各位，
多謝晒黃姑娘嘅分享。以下嘅時間咧，我就會交俾 KC 咧去做一個公開討論嘅環節嘅，時間係15分鐘。參加者亦都留意啦，出席嘅 QR code 咧將會喺呢一個環節度出現嘅，而位置咧將會喺熒幕嘅左上角。
OK， 首先我亦都希望所有觀眾啦，就可以踴躍啲，可以發問，可以喺個 Q&A 個 session 或者問答個 session 嗰度去問你嘅問題。我亦都見到已經有一啲問題開始問咗，亦都見之前Dr. Austin 已經開始答一啲問題啦。OK， 咁首先咧我就會每位講者發問2個問題去 warm up 一下先。OK， 首先我想發問問一問Dr. Austin 2個問題嘅。Hi Dr. Austin。Okay, I would like to ask you some questions first to warm up the audience. Okay, I saw that you already answered in the Q&A session about there's a question about the cultural differences in the and the translations. I would like to extend this a little bit more than just the translation. Is the entire system, okay, the classification and the concept, do you think that it can apply equally well for Asian countries or developing countries? Because the dimension covers social and environmental, and for these countries, the social and environmental environment would be quite different. So what's your take on this?
Yeah, thank you for the question. Should I answer? I can answer here and then also type as well, if that would be preferable. I would agree. Yes, we've used the Omaha system and My Strengths, My Health in other countries. And you're right, there might be some mistranslation potentially, but we found that it has worked quite well. Trying to then work with our international partners that speak the language and understand the culture in that translation, then going back out to communities and asking, does this make sense? If it doesn't, what might work better? So it has worked. It has been translated in Mandarin and other languages as well. I would agree there is some challenges there, but we've certainly tried to do our best to translate as best we can and then go out to the communities and test that. And it's a work in progress. We're finding it's still a work in progress, even in English, within speakers around even our area that we live. But it's something that we work on, and it's a challenge.
Good. Okay. Thank you. And another question is, I noticed in your presentation you cited 2 examples, and the major sample group for these 2 samples are targeted for age 25 to 44. Is there any specific reasons behind, or is this a sweet spot for your applications?
Yeah, I think a lot of that I could attribute to our community partners that we have. They were very engaged in the project. I think it was, especially thinking of the earlier project in 2020 with being in COVID, they really wanted to have some data from the community to really find out what was going on and where can we help the best. And so I think that our community partners were big champions, and they were really trying to get the word out within their community. Word spread that people were interested and excited about this. I think not just learning about where could we help and what could, some of the challenges are, but being able to have conversations about what's going well in the communities, especially during a time when it was quite challenging with COVID. Plus we have high opioid issues going on as well in our city. So I think that I attribute a lot of our success to our relationship with our community partners.
咁我想問一問Dr. Law， 因為佢都係喺同一個中心裏邊負責呢一個項目嘅。OK， 我係想問下Dr. Law。OK， 係。咁而家嗰個健康寶個程式主要都係做 assessment 啦，同埋提供一啲健康嘅資訊啦嚇。咁有冇啲諗法係點樣可以令到嗰個老人家其實真係通過嗰個 app， 除咗呢2樣嘢之外，係真係可以改變到佢嗰個健康嗰個習慣嘅咧？多謝阿 KC 個問題嚇。咁係啊，
咁其實咧，我哋嗰個健康寶咧，就喺設計上邊咧，都希望長者佢做完嗰個嘅測試之後咧，都可以掌握到自己嘅健康。所以我哋咧就有一個嘅report 有一個健康嘅總表啦。咁佢就可以去睇翻其實自己邊一項嘅項目。因為我哋有11個唔同嘅範疇去做一個篩檢啊，咁其實邊一個項目佢較為比較弱啲嘅，咁係可以去再跟進咧。咁其實呢個都係提醒翻佢可以攞住呢一個嘅檢測嘅報告啦，咁同翻自己嘅醫護人員又好，或者佢嘅照顧者去商量翻，咦，其實可以再點去跟進翻佢呢啲較為需要係跟進嘅項目咧。咁然後其實因為我哋呢一個程式都係一個免費程式，佢係隨時隨地都可以做嘅。咁我哋期望佢可以就即係一個長時間去定期做一個跟進，再次去重複嗰個 test 咧，咁變咗佢就可以知道自己嗰個健康狀況，同埋因為我哋亦都會建議咗佢有啲唔同嘅跟進嘅intervention 啦，咁樣，咁我哋期望佢可能做完一輪，譬如可能 frailty， 佢做完一輪一啲 exercise 之後，佢有啲 improvement， 再做嗰個 test 嘅時候，其實佢會睇到自己嘅 improvement 咧，就更加去鼓勵佢繼續去處理自己嘅健康問題啦，咁樣。咁當然啦，頭先 Maggie 都有提到啦，我哋期望即係長遠地係再有一個 further development 咧，即係再去令個程式更加可以推高一線，就係喺嗰個 center base 同一啲唔同嘅 NGO 可以再有一啲合作，去睇下喺如果係中心嗰個應用層面可以再多啲唔同嘅發展，我哋都係期望嘅。唔該晒。
多謝你，多得咯。OK， 跟住我想問一問阿 Mancy 就關於嗰個你個 presentation 關於健康嚮導嘅。OK， 咁我覺得嗰個服務本身係非常之好啦嚇。咁尤其是其中一個主要嘅 concept 就係會用咗一啲所謂一啲peer 嘅 health coach 去幫助去做呢件事。咁但係調翻轉亦都會唔會引起一個問題，就係點樣可以保障同埋監察到呢啲 peer coach， 因為始終佢都唔係 healthcare 嘅 professional， 嗰個 service quality 咧，會唔會擔心佢哋同個病人傾談嘅時候，可能 make 咗一啲advice， 但係嗰啲嘢係未必好啱嘅咁樣，會唔會有呢啲咁嘅擔心咧嚇？
多謝 KC 嘅問題啦，咁樣，咁我哋其實都有咗一啲嘢咧去基貼佢哋嗰個我哋嗰個服務嗰個質素嘅咁樣。咁首先我哋成個健康嚮導咧本身都有一個好well developed 嘅一個 framework 咧，去提供培訓俾呢一班嘅義工啦。咁其次咧喺義工去正式接個案之前咧，我哋都會同佢咧係要完成實習，真係 OK 咧，先可以正式開始成為呢一個義工啦。咁我哋每一位嘅義工咧都會安排督導俾佢哋。咁所以當佢哋可能有一啲嘅困難啦，一啲問題出現嘅時候咧，都可以去 consult 翻我哋嘅督導啦。咁另外咧就係我哋每個月咧其實都會有一啲義工月會，咁咧就係俾一班義工咧去就住佢哋接嘅個案，可能面對一啲狀況會有一啲交流啦，同時咧喺個月會上我哋都會有一啲技巧啊或者知識上面嘅一啲提升嘅，譬如邀請一啲嘅講者過嚟去提升佢哋呢方面嘅一啲嘅知識啦。咁另外我哋都會要求咧，就係啲義工喺面見完之後咧，要交翻一啲好簡單嘅recording 俾我哋嘅。咁等我哋都知道佢哋喺面見嘅時候其實係做過啲乜嘢啊，發生咩事啊咁同埋喺個參加者去參加完我哋呢一個嚮導嗰個服務嘅時候咧，我哋都會收翻一啲嘅 feedback form。咁所以就喺各個唔同方面啦，無論係即係提升equip 呢啲義工佢哋嗰個嘅知識啦，同埋係監察我哋個服務上，我哋都有一啲方式去做嘅咁。
我了解你哋嘅服務可以有線上形式，可以線下形式，可以 hybrid 嘅。咁你其實有冇一啲數據或者有啲 experience 就係話邊樣 模式其實係好一啲，或者對嗰個病人嚟講，或者對嗰個health coach 嚟講，即係邊樣係會 effective 啲啊？
我哋暫時就未有話即係做咗一個 research 去對比兩者，大家嗰個感覺覺得係點啦咁。不過我哋見咧就係因為都係一個大趨勢下啦，即係疫情之前比較嚴重嘅時候咧，的確好難去面見，即係就算可能佢哋好覺得面見好啲，但係的確即係太擔心疫情，根本都冇可能可以做到，所以都要轉一個電子嘅模式去做。咁所以我哋都喺今次即係去訪問咗部分參加者，希望就係即係收集翻佢哋嘅一啲建議啦，睇下如果我哋日後真係需要用有機會要 keep 住用一啲電子模式啊，或者混合模式去做嘅時候，可以點樣好一啲咁啦。
OK， 多謝 Mancy。OK， 其實時間就差唔多啦，咁就我想 take 呢個時間就係一個 final 嘅 wrap up 啦，睇下每一位講者有冇一啲 additional 嘅嘢想補充啊，或者問其他講者咁樣。OK，let me start with Dr. Austin. This is the final wrap up. OK, questions. OK, just see whether each speaker have anything to supplement, okay, to wrap up the session. So, Dr. Austin, may I start with you?
Yeah, I just want to say thank you, and it's been a privilege to hear about all the projects that you're all working on related to digital health and e-interventions out in the community. It's been really inspiring, and I concur and agree with a lot of the things that you were talking about related to working with older adults, the health literacy components. So I just really appreciate being here. Thank you so much.
Dr. Long, 你有冇嘢要補充？
咁都好高興可以參與咁有意義嘅一個 discussion 啦，咁同埋都聽到好多唔同嘅發展喺個 eHealth 上邊，咁都期望我哋大家一齊努力啦，喺呢個平台上邊係啦，咁唔該晒。
OK， 多謝你。OK，阿 Mancy。
好啊，係啊，都好多謝大家嘅分享啦，即係我覺得即係每一個嘅分享咧，我哋都喺上面咧可以有好多學習啊。或者一啲可以吸收到之後咧，可以喺我哋個服務上面去再做好啲，或者可能未來又可以有多啲嘅交流啊、合作咁樣，咁所以都好多謝大家。
OK， 咁我亦都多謝大家。Once again, I thank you, all the speakers for the excellent presentation as well as the discussion. I also learned a lot from the sessions. Thank you.
多謝晒 KC， 多謝晒幾位嘉賓嘅分享。上午嘅環節咧，我哋已經圓滿結束㗎啦。接住落嚟咧，我哋係 lunch hour 嘅時候啊，係啊，咁我哋下午嘅環節咧，將會喺2點半鐘開始嘅，大家可以早15分鐘登入。我哋稍後見，多謝。